Hi, everyone. Happy Thursday. Welcome in. My name is Drew. I'm your clinical advisor, or I am a clinical advisor here at Functional Medicine Academy. And this is our clinical confidence round. So, thank you so much for joining me. I see people are jumping in. Thank you so much for being here. Give me a thumbs up or put it in the chat if you can hear me okay. And if you are a first timer here, I love to connect with everybody here and definitely want to see everybody's presence. Okay, we've got a thumbs up that you can hear me okay. Wonderful. Well, we're going to go ahead and get started. We have a special case for today that we are going to go through, and we will also talk about what this is supposed to be for. So, clinical confidence round is a weekly live. So, I'm going live here every single week, and we talk through a advanced case that was submitted by one of our practitioners in our program. And so last week, we wanted to take a look at and review a serum blood level or serum hormone panel and also some blood labs. So we're going to take a look at those today. And we'll also going to talk about a treatment plan and protocol just to help you understand how to actually phase out your protocols and really be more of a confident clinician when you're stepping into functional medicine. A little bit about me. I'm a registered nurse. I'm also a functional medicine practitioner. I've been practicing almost 3 years now. And I just feel like I'm getting into functional medicine. There's so much to learn. Of course, I have a lot of experience, but I do. One of my biggest struggles was learning about how to actually phase out protocols. What are the things that we need to start with based off of what we're seeing, and really identifying different patterns, because what I learned in nursing school definitely was not the reality of things when it comes to helping people reverse chronic illness and really optimizing their health. So I have something special. This is actually my personal patient that I support. And she came to me, she found me on social media, and she was really interested in healing her gut. She was constipated, and she also she had amenorrhea as well. So she didn't have her period, I think, since May of 2025. And so I was like, okay, this is a big concern. She's a young girl. She's 17 years old. And I am really going to go through what those blood levels are. I'll show you what those are, and then what we did when it comes to recommending a treatment plan and protocol, and walking you through my thought process there. So as always, please feel free to put questions in the chat. I'll be monitoring those, whether it's about this case or even general clinical question. I will be happy to answer that. All right, let me go ahead and share my screen. Give me a second here. There we go. Okay. So this is my patient's blood labs. I actually just got these back. She started with a GI map that I have her on, or a protocol around. And then now what we'll do is add in some of her blood labs, especially because she's had amenorrhea, and I wanted to know what I could help her with, or decide if we need to give her or recommend a OBGYN, or have her follow up with her PCP, because of course with amenorrhea we are definitely concerned about her fertility, and since she's a young girl, I didn't want her to be struggling with fertility, especially if and when she decides to get pregnant. We're not going to have that issue. So with that being said, I ran a whole bunch of labs. I ran an anemia panel, a CBC, CMP. What else did I do? Some blood markers right there, some lipid panel, a full thyroid panel, and just some of her sex hormones as well. So what we'll do is go through, I'll tell you a little bit about her. We'll go through some of her levels right here. And then I want to walk you through the abnormal levels and identifying the patterns, and not looking at certain markers in isolation, but understanding them as a whole. So that way it can really guide your treatment plans and protocols. A lot of the things that we are actually going to be talking about is her thyroid. I'm actually going to scroll down here where we can see all of these thyroid levels, because this is where the crux of a lot of her protocol is centered around. Because she's a very young girl, some of the things at first glance, it might not make sense because her TSH is not super high by any means, but we do have a really low T3 and also two T3s that are both very low, the total and also the free. But everything else looks pretty quote unquote normal. So, in a conventional sense, there's not really much that we would do for this patient. But of course, when it comes to functional medicine, we can really start to prioritize how the reason why she's experiencing this, and then also a treatment plan and a protocol to really get her back to being optimized. Because the biggest pattern, let's see. Well, the biggest pattern that I'm seeing here, or actually, before we go into patterns, let me talk to you about this patient. So, I did explain that she hasn't had her period since May of 2025. She is a very stressed person, so she's under a lot of stress. I think her parents put a lot of pressure on her to get into an Ivy League school, and so she's doing a whole bunch of like college applications right now. She's about to graduate high school, so she's under a lot of pressure for that. She travels frequently. She also is a chronic undereater where she hasn't been eating nearly enough food as she needs to. So when we first started working together, that was a big priority. And that's something that you will very likely see within your practice. It really is going to be people typically and chronically more commonly than not undereat, and that's really going to affect the labs that we're seeing, because that's going to be a big thing when it comes to her thyroid levels with her T3, both of her T3s being low, and also her FSH, her LH, her progesterone, and her estradiol. Everything is very much suppressed. We also have vitamin D. Vitamin D is also very low as well. We want to see that at about 50. And so all of this in ice and together when we're looking at things is really just connects to a big everything is just very suppressed. So we have a lot of the HBG, HPA access that's definitely being hindered, which we're seeing because of the low sex hormones. And so right now, overall, the body is in a state of reserve, of preservation. It doesn't really know if it's going to get food or when it's going to get food again. And it's asking that if the body is safe to run these processes right now, because a big priority number one after looking at these labs is to signal metabolic safety to the hypothalamus, because the hypothalamus is what's regulating, and it can tell it's going to be that governor, and it's going to tell the body whether it can run its processes smoothly, or if it's going to be, hey, we need to actually slow things down because we don't have the necessary building blocks to really run these processes, because it's going to perceive the state of chronic famine as a threat. And until that safety is really established through consistent fuel, the body is going to shunt, and specifically talking about this thyroid, it's going to shunt T4 towards reverse T3, which you can see is getting a little higher from a functional standpoint. And it will, or it's going to simply reduce what we're seeing here, the active T3, because that's our quote unquote metabolism type of hormone. That's our active thyroid hormone. That is the one that really will give us our energy, and the symptoms really follow that thyroid hormone right there. And so it's interesting because we've been working on her diet, I would say, for about 2 months before that. And it's a really good reminder that these things, to really help the body learn that it is safe to run these processes, it takes time, especially when it comes to amenorrhea. We could be working on this for another 5 to 6 months until her period starts to come back and hormones start to normalize. I would say a minimum of 3 months. But this is a really good indicator of really supporting her body for its metabolic health, as well as getting it the support that it needs. Let's see. So those are that's the biggest pattern that I'm seeing here. We definitely have the ferritin that's a little high, but usually when ferritin's high, that's a symbol or is an indication of an acute phase reactant or inflammation. But because everything else when it comes to her iron looks okay. Excuse me. Her HSCRP looks fine, and so this is might just be like just a short phase reactant where it's not inflammation, where there's no inflammatory process, but definitely something to keep an eye on. Her metabolic health looks good, but I will say that this fasting insulin, I mean, it's right on the cusp of the normal level, but it's definitely low when it comes to functional medicine. Ideally, we want insulin to be, I believe, at the lower end in the threes, 3.4 maybe. Don't quote me on that, but I definitely know it's in the threes. And so anything that's lower than 3 is definitely a concern. So with her insulin level, that's another signal that her body is in that state of preservation, of famine, and so it's going to reserve as much as possible. Hemoglobin A1C 5.2, which is interesting based off of the food that her body might not be, getting a whole bunch of carbs, and she is under eating. But a lot of this, and I didn't run a cortisol level. I it did not. I didn't have it on this panel, but this is something that is interesting as far as the cortisol and having it contribute to that glucose level rather than the food that she's eating herself, because she tracked her food. She's a very healthy eater. We definitely want to add in more carbs and more complex carbs to make sure that we're getting the thyroid the support it needs for that conversion. But yeah, interesting that this is right on the edge of that functional range. I think 5.3 and above is when it starts to get out of that functional optimal range. Those are the biggest patterns. Of course, we talked about the reds. MCV is high, so definitely the need for B12. So there could be a little bit of B12 insufficiency right there with some nutritional markers. MCV is the consistency of the size of red blood cells. And so when they're really big, these blood cells are very big. And so this means that there is going to be that inconsistency, and we do need that B12 to help when it comes to supporting with the macrocytic anemia. Microcytic, but everything else looks okay right there. Glucose is a little low compared to where I would want it to be, especially if she's not fasting. Interesting, because I did tell her please fast, but I wonder if it was a little bit later on in the day. Might have been. Oh, I mean, it was 9:40. It's fine, but anyways, yeah. So even with her not being fasted, that's still, if she was eating, I would definitely expect this to be a little bit higher, and also the insulin as well. So again, the body is really focusing on that preservation. Trying to find if there's anything else. Yeah, we talked about her sex hormones all just being very low. She hasn't had a period, so basically, we can't really follow some of the recommendations on here. But if we look at some of the ranges when it comes to follicular phase, ovulation phase, and luteal phase, I mean, she's on the very low edge of each one of these. We don't know what phase that she's in, of course, but even just looking at how low it is compared to where she should be is very low. Also, where you see the LH, so the luteinizing hormone, that is low across the board. Even if she was, depending on which phase she was in, everything is very low and suppressed. Progesterone, we would expect that to be super low. We don't really know where she is in her cycle, but that's definitely low as well. So everything is just low. Everything is suppressed. Vitamin D, yeah, we did mention that. Everything is just super low because the body is in conservation. So this is a pretty, I would say, straightforward test to address and support and treat. Oh, I also wanted to mention, sorry, I didn't call out the triglycerides. That's another indication of really that famine state, because the body is really trying to preserve. Cholesterol is fine. HDL is okay. The LDL, I know that that's marked as high, but I believe in the functional range. it is something that we want to make sure that it is under 120. I do remember running it through our software, LabDX. If you're in our program, you have access to it, but it is a great resource when it comes to defining whether or not these labs are going to be in optimal range, functional medicine range versus just the normal range right there. Because you see how many things that I pointed out that are quote unquote normal functionally, but are something that can tell another story when it comes to functional medicine, which is really cool. All right, well, let's get into interventions here. So we talked about the priority one is going to signal that metabolic safety, tell the body that it's safe. Really consistent meal times, making sure she's getting enough protein, some good carbs, healthy fats, and really having her track it. I know that she's been telling me that she's been getting a lot better when it comes to her eating, which is great. But now we just have to be consistent with it, right? So we really have to be consistent. So show our body that it is safe to recover. The next thing that we really want to do is because that she's under a whole bunch of stress, and that's a big leading reason why we're seeing a lot of things that we're seeing, but also at the same time, really how stress is impacting the hypothalamus as well. That's going to tell, hey, we need cortisol. We need cortisol to make sure that we're able to, stay online and to run the processes. So we're relying more on cortisol rather than our like the fuel that we're actually getting from our body, because that's going to be a danger signal. It's going to signal to our brain that it's a danger signal, and it's going to suppress TRH output. It's going to disrupt the hormonal rhythm necessary for ovulation. So stabilizing her sleep and cortisol rhythm is really going to be required for the brain's permission for metabolic expenditure. That's a really good way to say it. I'm going to talk to her about getting a cortisol test to see exactly where that's going and pull in some more personalized support. But I did recommend, if she is feeling stressed, to lean on those supportive adjuncts like GABA, mindfulness, taking some small breaks throughout the day to just really start to lean in and breathe, which is very powerful. Morning routine and evening routine, really setting boundaries around that self-care is a lot of what I teach about and what I really emphasize when it comes to my patients working with me. And also another big priority is to replenish those micronutrient and substrate preserves, because if we see this low T3 right here, this is going to rely T3 in that conversion. It is going to require cofactors like selenium and zinc for the deodenase enzymes to function. Those deodenase enzymes are in the liver, and that's what really conjugates that T3 and changes it into T4. We're really needing some more T3 right here. And we also have potentially, because of that higher ferritin, some iron sequestration. And because this system is lacking the regulatory tools for immune and hormonal balance. So overall, the theme, again, is going to be getting the body what it needs to run its systems. So a really good thing right here to add in, which I have her on, is going to be like a multivitamin, multimineral, having her take that every single day to at least show the body that, hey, we have something. If we're not getting it from food, we need to get it from somewhere. And so supplementation, especially when it comes to a multivitamin, is very helpful. So those are our big priorities right here. So how would we really phase this out? We'll talk about that, and then we'll go into other, addressing some of the other dysfunctions that we're seeing. Because the phase one is definitely going to be always stabilizing. So I like to focus on three phases when it comes to building my protocols. Number one is stabilizing. Number two is reducing or clearing out. And then number three is rebuilding and optimizing. So if we're trying to stabilize, we really want to restore that circadian rhythm, making sure sleep is consistent. She's getting a lot of that rest. We want to establish like some electrolyte and vitamin D status, like those micronutrients. This is when, again, we would do some vitamin D, maybe some, I already said it, a multivitamin as well, maybe even some CoQ10, things to help the mitochondria as well as the rest of the body run its systems. Number two is really going to be about optimizing the T4 to T3 conversion by making sure she has enough cofactors to be able to support that, because her T4 is okay. The thyroid is doing what it's supposed to be doing. It's just a matter of receiving those danger signals, telling the body that it's okay. We can't turn things up right now. And so making sure she does have that selenium and zinc to prioritize the T4 to T3 conversion, because again, her T4 is good. We just really needed that conversion so that way we can get some more T3 in the body when it's ready, right? We don't want to force it, but when it's ready, we have stable meals and all the other stuff that we've been talking about. And then, of course, when it comes at phase 3, which is going to be some of the bigger goals right here, is HPG access recovery. That's hypothalamus pituitary gonadal. That's more of like when we talk about fertility, return of her menstrual cycle, prioritizing and optimizing muscle mass as a glucose buffer as well, which is very helpful. So that way we can have that long-term metabolic flexibility. I am a big advocate of getting and doing some weight training. Of course, she's not ready for it now, but we want to use movement and exercise as a stabilizer rather than as a burden to the body. She's not nearly eating as much, where we don't want to push her to do something that her body's not ready for, because we need adequate hormone testing, and we need the adequate thyroid hormone. We need her metabolic health to be stabilized before she goes out and, for example, does like a high intensity workout class, which she told me that she did before I had these labs. And I was already saying like, no, that's not a good idea. And she was saying that it took her a long time to recover from that workout class. And so I was saying that, okay, well, this is a big sign where we need to scale it back and just prioritize walking right now, and maybe some stretching or yin yoga, whatever it might be, but we stay away from the high intensity stuff. So when it comes to her nutrition, there's a lot of things that we really want to emphasize. For somebody who's so restricted right now, or restrictive when it comes to their eating, I always like to say, hey, we're not going to try to take out a whole bunch of things. We really actually want to try to add in as much as possible. So eggs, wild-caught fish, or seafood, rices, quinoa, oats, potatoes, some of those good starchy carbs, root and colorful vegetables, healthy fats like olive oil, avocado oil for those monounsaturated fatty acids, and also some seeds are very helpful. We could get her on doing some seed cycling to help when it comes to ovulation and getting the body what it needs. And that can also help when it comes to her constipation as well. We definitely want to avoid, she has a no trigger to dairy. So definitely, cutting that out. I only want to cut things out if she has an adverse reaction to things, or she is a known sensitivity or allergy. We want to, of course, ultra processed foods. I never really recommend those because that can, expedite the risk for oxidative stress and metabolic noise. And also any caffeine after 10 a.m. Definitely want to make sure she's going to drink caffeine, that it is something that's paired with her breakfast. So that way we don't get that cortisol spike, which will show our body that, hey, we're trying to be energized, but we don't have the foundational stuff that we need. And then, of course, like really large late night meals can disrupt her sleep and also HPT access. So yeah, those are the biggest things. I really like for phase 1 supplements. I told you the vitamin D, maybe even some magnesium glycinate to really support the HPA axis. It's really good to support the nervous system. Multivitamin B complexes are very good. Then in phase 2, we can really start to optimize more of that thyroid conversion. Usually a multivitamin will have selenium, zinc, and iodine in it, like a little bit, but we can really focus a lot more on that conversion by adding in some other selenium and zinc, maybe even omega-3 to help balance her hormones, right? And then if her cycles do remain irregular, a inositol, so that'll be something like in phase 3 you could consider, or I would consider. We could do that twice daily because that really helps when it comes to improving ovarian signaling sensitivity. And then again, we could do some CoQ10 to really support that mitochondrial recovery, especially because she's said already that when she's worked out, she gets very, very, very sore. So I'm sure that her mitochondria are not even running, they're not even getting the nutrients from the food that they need. And so making sure a multivitamin, of course, is something that I would always have in the first line of things. But yeah, making sure that we really do have all the things. We're really focusing on those 3 stable meals. And then we'll really start to help her when it comes to bringing her cycles back, which will be really fun. Okay. Function health. What type of support do you give to clients to start weight training if you're virtual? Oh, good question. So, yeah, I'm not a personal trainer. So, what I usually do is either recommend them to reach out to their gym and get a personal trainer if that's what they are interested in, or I just start to give them a very simple progressive overload weight training program that I have made with AI. So I usually just chat GPT. I talk to the bot about what my patients' goals are, where they're at. And then I just make sure that we are prioritizing again that progressive overload. So that means that we're increasing weight very subtly and steadily. Maybe each week or eat every 2 weeks. The biggest thing is just making sure that we are increasing weight every so often as her body allows. But that's not even going to be until way after phase 3. I would want to see her menstrual cycle come back before we're even thinking about adding in some weight training. But yeah, that just definitely depends on if she has a gym. I know it's very dependent on the person's situation. If she's not able to go to the gym, then I would do like resistance bands. I know that that's not technically progressive overload, but that's typically what I recommend for my patients if you are virtual. All right, everyone, let me stop my screen share. Does anybody else have any questions about this case? Does anybody else have any questions about anything that we discussed? Any general questions? We have about 3 minutes before we'll shut it down, but definitely want to thank you so much for being here. It was really fun. If there's any ideas about what other tests to do and go through, I really love doing the blood test because you could really talk about patterns. So we could do another blood test. I think we were talking about doing like a hormone test next time as well. So we could definitely do a hormone test, like a Dutch test, a advanced test. I really like those as well that we can do too. So, all right. Thank you so much. If there's no questions, I'll let you guys go. I'll be back next week at the same time and we'll go through another test. Question. When you order basic sex hormones as an add-on to regular blood labs, yeah. So what I do typically first, if they haven't had any serum blood labs for at least 6 months, or if it's more than 6 months old, I always start with the serum blood panels. There's so much you can see from there that are impacting her hormone levels, or somebody else's, right? But you could also you can definitely do a Dutch test, but I like to start with serum hormone levels because it will show you so much. Unless they maybe have had serum hormone levels done before and it really didn't show much of anything, and you're suspecting some estrogen detoxification issues. The Dutch is one of my favorite tests. It's very comprehensive. I really love it. But it really depends on the patient that you have in front of you. I think that a lot of times serum hormone levels is enough. But if you really have a perimenopausal patient and you really want to look at, how well they're methylating, detoxification pathways, their progesterone levels, DHEA, testosterone, their cortisol levels as well, they have the 4-point cortisol test. So then I would do the Dutch test. But typically the serum blood levels are enough, but it depends on the person. With her, I wouldn't have gotten a Dutch because she's amenorrhagic. I don't know if I'm pronouncing that right, but she has amenorrhea, and I know that her hormones are going to be off. So let me just look at her serum hormone levels and all the other things that could be contributing to it, so we can understand the underlying pattern. So really, really good question. Yeah, great question. All right, everyone. Well, I am going to hop out. Yeah, of course. Thank you so much for coming in. We'll see you guys next week. And feel free to comment down below, even after I'm done, for another test that you would like to have reviewed or another test that you would like to have gone over. And we'll go from there. All right. Bye-bye, everyone.